Good morning again. We'll talk about incidental pancreatic cysts, and these are tough, my potential conflicts of interest. We see them very commonly. Studies have shown on CT between 2 and 3% of patients will have incidental pancreatic cysts, and on MR up to 20% in some studies. As you know, we see these very commonly, and it could be a real question as to how we deal with them, because they're so common that if we choose to follow everybody at short intervals, we're using up a lot of medical resources and a lot of money to do that, and we're putting the patients through a lot of examinations. So it's helpful to figure out exactly how we should deal with them. The problem is we're not quite there yet. There's still a lot of questions to be answered. So most of the information that we have about the natural history of incidental pancreatic cysts comes from surgical series and imaging pathologic correlation in these surgical series. There are no what would be considered higher order information, studies like prospective randomized controlled trials that would give us very high order information about how we should deal with these things. So because we don't have that higher order information, all of the information or the way we evaluate these patients is based on consensus guidelines that have been put together by experts from various fields. The first consensus guidelines were what are called the Sendai criteria that were put together by the International Association of Pancreatology in Sendai, Japan, and which were published in 2006. And they were updated 6 years later at a meeting in Fukuoka. After additional information became available and there were improvements made on the original recommendations. And since then, there have been many other guidelines that have been developed. The American College of Radiology put guidelines together or recommendations in 2010 in a white paper on incidental findings, all types of incidental findings in abdominal CT. And it's a very useful document. But since then, the members of the Incidental Findings Committee has put together more specific documents on individual types of lesions, and their updated document on pancreatic cysts came out just recently, a few months ago, and I think it's an improvement on the original document. There was also a European consensus statement that came out in 2013. There was an Italian consensus guidelines that came out in 2014, and the American Gastroenterological Association put out their guidelines in 2015. And the problem is, as you might expect, these guidelines differ. So it can be very difficult because there's a lot of discrepancy as to how these various expert panels would like us to follow these patients. So my approach to incidental pancreatic cysts is the Donald Rumsfeld approach. And what I mean by that is back in 2002 at a Department of Defense press briefing, he made what is now a fairly famous statement in which he said, there are known knowns, things we know, there are known unknowns, things we know we don't know, but there are also unknown unknowns, things we don't know. And I think that's true of pancreatic cysts, that we have a lot of information from a lot of studies, so we know a lot about the natural history, but there are a lot of things that we know we just haven't determined yet, that we still need to work out. And in addition, I'm sure there are things that we haven't even thought of that eventually will be determined to be very important factors in how we deal with these patients that we just really aren't aware of yet. So those are the unknown unknowns. So for the next 15 minutes, I'd like to discuss what we know and what we don't know about incidental pancreatic cysts. Well, some of the basic things that we do know are that the prevalence of incidental pancreatic cysts is substantial, and it increases with age. We know that 90% of incidental cysts are less than 3 centimeters, and most of these incidental cysts turn out to be branch duct, intraductal papillary mucinous neoplasms. We know that cysts that contain a solid component are associated with increased risk of malignancy. We know that a branch duct IPMN in association with a dilated main pancreatic duct is associated with increased risk of malignancy. And we know that pancreatic cysts that are larger than 3 centimeters also are at increased risk of malignancy. On the other hand, an incidental pancreatic cyst that is smaller than 3 centimeters and does not have any worrisome features like a solid component or a dilated main pancreatic duct has a fairly low risk of malignancy, and various studies have estimated that that risk is in the range of maybe around 1% to 2% per year. Now, another fact that is disturbing, that has come to light over the last 5 to 10 years, is that a small but substantial percentage of patients who go to surgery to have a branch duct IPMN resected are found to have concurrent pancreatic ductal adenocarcinoma. In addition to that, other studies have shown that patients who have one or more pancreatic cysts have an increased risk of subsequently developing a pancreatic ductal adenocarcinoma. So this is kind of disturbing. And the adenocarcinomas that develop in these patients are not always related to the cysts. They may be remote from the cystic lesions. So it appears that there may be a field defect in these patients who have pancreatic cysts. And I'm not going to say much more about that because Dr. Gore is going to focus on that in his presentation. But I think one of the things that we still don't know is how do we assess these patients? Is this true of all pancreatic cysts, that they put these patients at increased risk of developing adenocarcinoma, or is there something different about the cysts in these patients that we will come to learn that will give us a clue that these patients are at higher risk than others? And so there's a lot that we still need to learn about these, and I'm sure it has something to do with genetic mutations, but that's something that we still don't really have a handle on. Now, another thing we do know is that a substantial percentage of individuals who have pancreatic cysts have multiple pancreatic cysts. And so some things we don't know are whether these patients with multiple pancreatic cysts are at increased risk of malignancy. So far, there haven't been very many studies that have looked at this, but the ones that have are conflicting. There have been 2 studies that have shown an increased risk of malignancy compared to solitary IPMNs, but there have been 2 studies that have shown an increased risk in patients who have multifocal IPMNs. And this one in particular is kind of disturbing. This was a study that was from Johns Hopkins University, and they looked at 52 patients who had 4 or more pancreatic cysts, and when these patients went to surgery, they found that 1/3 of them had high-grade dysplasia or invasive carcinoma, and 1 in 6 had a coexistent ductal adenocarcinoma. So this is one of the studies that shows that there may be an increased risk in these patients with multifocal disease. So I think the jury is still out on this. There's conflicting information, and we need to learn a lot more about how to deal with these patients with multifocal disease. So to summarize, the features that are associated with increased risk of malignancy are a solid component, a dilated main pancreatic duct, an overall size greater than 3 centimeters, and some investigators have looked at growth rate, and some studies have indicated that the faster the growth rate, the more likely that that lesion will become malignant. But I don't think we have enough information about that yet. And another thing that I haven't mentioned is symptoms. Now, by definition, if we're talking about incidental pancreatic cysts, we're talking about asymptomatic patients, or patients with symptoms that we can tell are not related to the pancreas. But if a patient has abdominal symptoms that could be related to the pancreatic abnormality that we've identified, then that puts the patient in a much higher risk category. So that we're not talking about patients with symptoms when we talk about how to deal with incidental pancreatic cysts. Now, what about management? And this is where we run into problems with the various guidelines. I think there's a pretty good consensus among all the guidelines that if we see what we think is a branch duct IPMN that is 3 centimeters or smaller and has no worrisome features, then we can follow this lesion with imaging. The problem arises when we try to determine how should we follow them, what intervals, at what intervals should we follow the patients, and what we should we do if we see growth. So, for example, if you look at all of the different guidelines that I showed you earlier, for lesions that are less than 1 centimeter, the guidelines recommend anywhere from 1 to 3 year follow-up intervals. There's a pretty good consensus that if the lesion is 1 to 2 centimeters, a 1-year follow-up interval makes sense. If there's growth, most of the guidelines recommend that if it grows to between 2 and 3 centimeters, we should decrease the follow-up interval to 6 months. But if it grows to more than 3 centimeters during our follow-up period, some guidelines recommend resection, whereas others recommend continued surveillance if there are, again, no worrisome features. And if the lesion starts out between 2 and 3 centimeters, the guidelines range anywhere from a very short 3 to 6 month follow-up to a 1-year follow-up interval for this size lesion. If there's no growth, the recommendations recommend anywhere from a 1 to a 2-year follow-up interval. And if there is growth to greater than 3 centimeters, again, some recommend resection, whereas others recommend continued surveillance as long as there are no worrisome features. Now, most of the guidelines do recommend that if a lesion starts out at or grows to at least 2 centimeters, that we should strongly consider cyst aspiration with ultrasound guidance, endoscopic ultrasound, to assess the cyst fluid for various features. And the cyst fluid analysis that is generally done in clinical practice includes evaluation for CEA, amylase, and cytology. And these are helpful because it has been shown that a high CEA is associated with mucinous lesions as compared to serous lesions. Now, CEA doesn't tell us whether or not a lesion is malignant. It will just give us information about whether we're dealing with a mucinous versus a non-mucinous lesion. And amylase is helpful as well. And the way it's helpful is that if we have a lesion that is a mucinous lesion, and we also have a high amylase, that indicates that we're dealing with a lesion that communicates with the pancreatic duct, which would be an IPMN. If we have a lesion with a high CEA, but a low amylase, then we're dealing with a mucinous lesion that does not communicate with the pancreatic duct, so that would be a mucinous cystic neoplasm. And if we have a lesion that has a low CEA, so it's not a mucinous neoplasm, excuse me, but the amylase is very high, then we're probably dealing with a pancreatic pseudocyst. Cytology is helpful. If we get a positive cytology, obviously we've made a diagnosis of malignancy, and sometimes we could make a diagnosis of a specific malignancy. But the sensitivity of cytology is fairly low, but it can be helpful. So we always get cytology as well. Now, DNA analysis is very promising, but it's not done on a routine clinical basis because it's fairly expensive and it's done only at certain medical centers. But DNA analysis looking for mutations such as KRAS and other mutations has been found in some studies to be predictive of a lesion becoming malignant. So I think it has a lot of potential, but there's not enough information yet to rely on this as a definitive way of determining whether a lesion is malignant or not. Now, a couple of things I'd like to point out having to do with follow-up. One big question that still needs to be answered is how long do we need to follow these lesions? Do we need to follow them forever till a patient gets to a certain age, for a certain period of time if it stays stable? Well, the only guidelines that address this, most of the guidelines don't really address how long we should continue following the lesions. One that does is the AGA guideline, and what it says is that if you have a lesion that is less than 3 centimeters, you should do a 1-year follow-up, and if it's stable, then do 2 2-year follow-ups. And if at the end of 5 years the lesion has not changed, then stop following it. The new ACR guidelines also address how long we should continue following these lesions. It's a little bit more complex, but I think it makes more sense than the AGA guidelines. So for lesions between 1.5 and 1.9 centimeters, a 1-year follow-up for 5 years, then 2 2-year follow-ups for a total of 9 years. And if at the end of that period there hasn't been any change, then the ACR Incidental Findings Committee feels that it is reasonable to stop follow-up at that point. If you have a lesion that is 2 to 2.5 centimeters, the recommendation is to do 6-month follow-ups times 4, so for a period of 2 years, then do 1-year follow-up for 2 years, and then do 2-year follow-ups for three times for a total of 6 years. So we're at a total of 10 years. And I think that also makes sense. If you followed it for 10 years and it hasn't changed, particularly if you're dealing with an older individual, I think it's reasonable, although still we really don't have enough information to make that, to say that definitively that we can do that. But I think it's a reasonable recommendation. Another recommendation that the new ACR guideline makes is that if you identify a cystic pancreatic lesion in a person who is 80 years old or older, that you do a shortened follow-up. And what they recommend is 2 2-year follow-ups for a total of 4 years, and if there's no change, then forget about it. And I think that is reasonable as well. And then they also make a recommendation that to consider that if you're following a cystic lesion in an older patient and the patient gets to the age of 80, that at that point you might want to consider stopping follow-up. So I think those are reasonable recommendations, but when it really comes down to it, we really still don't have enough information to be definitive about that. One thing that I think is important to keep in mind is that the appearance that we see on our imaging studies doesn't correlate directly with patient management. It drives patient management to a large extent, but patient management really depends upon the age of the patient, comorbidities, the patient's willingness to undergo surveillance, the patient's surgical status, ability to undergo surgery, and whether or not the patient has a family history of pancreatic cancer. So to summarize, what are some of the things we don't know that we still need to learn? Well, one thing that I think we do a lot is we follow these very tiny lesions that are less than 5 millimeters. And one question I have is, does that make sense? Do we really need to follow these very tiny lesions? I don't think we have enough information to know that yet. Another question is, how long do we need to follow cysts that show no change? Still don't have enough longitudinal information to make a definitive statement about that. Are multifocal branch duct IPMNs associated with increased risk of malignancy? Conflicting evidence so far, so jury's still out. Are all pancreatic cysts associated with an increased risk of ductal adenocarcinoma, or is there something different about those that are? And can genetic mutation analysis of cyst fluid predict malignant transformation? A promising area, but still not enough information to make that a routine part of our clinical evaluation. And then there are the unknown unknowns. I'm just going to leave this slide blank because I don't know what we don't know. So I'll leave that up to you. So to summarize, the prevalence of incidental pancreatic cysts is very high, and it increases with age. The risk of malignant transformation is very low, in the range of 1% to 2% per year. The features that are associated with increased risk of cancer are a solid component, a dilated main pancreatic duct, and size greater than 3 centimeters. Patients with pancreatic cysts are at increased risk of developing pancreatic ductal adenocarcinoma. Consensus guidelines for follow-up and treatment vary. That's one of the problems. And there's still a lot we need to know about pancreatic cysts that we don't know. And finally, I think, as I alluded to earlier, I think the management decisions are best made on an individual basis and with multidisciplinary team discussion. It's not driven only by imaging, but by a lot of other clinical factors that play into the evaluation of these patients. Thank you very much for your attention.